quantify by standardized questionnaires such as the Ocular Surface Disease Index, the Dry Eye Questionnaire, or with some initial questions suggested by the TIFOS devs2. And together with the medical history and the assessment of these symptoms, ocular surface disease is usually diagnosed based on the slit lab examination. Using different dyes, as we have seen, the corneal epithelial defects and conjunctival staining can be made visible, and we can also determine the tear breakup time using fluorostain. The major strength of the slit lamp microscopy is a global availability in all clinics and its low cost, but they have some limitations. The evaluations are subjective. We have no objective documentation, only we take videos or photos. They are truly non-invasive because we instille dyes into the eye, and these dyes may interfere with the tear film homeostasis. Also, we can use some invasive tests, for example, the tear osmolarity, the Schirmer test, or the impression cytology. And if we see the algorithm of the TIFOS devs2 only with the symptoms, with the T-BUT, with the osmolarity and the ocular surface staining, we can detect if we have a dry eye, and we can classify into evaporative or aqueous deficient eye, dry eye. But if we see the ISCRS preoperative OSD algorithm, these authors suggest that we can also use some optional non-invasive OSD test to help establish the OSD subtype. So what can be the role of imaging technology in ocular surface disease? With this technology, we can assess the tear film breakup time objectively and in a non-invasive way. With some instruments that projects a grid, plethora rings, or other reflection patterns onto the cornea, these devices record the projected patterns when they become distorted. And as you can see in the picture, and this measurement can be repeated for reliability. Some devices can actually measure the non-invasive BUT, for example, the keratograph, some topographers like the Antares, or interferometers like the LipiView 2. And it's interesting because the value obtained with these approaches have high values of sensitivity and specificity for detecting dry eye disease. So we can use the non-invasive BUT for the screening for dry eye, the diagnosis and staging of dry eye disease, especially in the evaporative type, and also for monitoring the treatment efficacy. So in comparison with the classical BUT using fluorescein that is invasive, that is quick, inexpensive, but is affected by the technique and the dry eye concentration, the non-invasive BUT is non-invasive, is more natural, more consistent, repeatable, objective, but it requires special instruments. We can also use the interferometry. This is a non-invasive optical technique used to assess the thickness and stability of the tear film. Several devices use this technology in order to evaluate the tear film thickness, the distribution, the stability, and the dynamics. With interferometry, we can measure the lipid layer thickness, and we know that a value below 60 nanometers has a high specificity in the diagnosis of meibomian gland dysfunction. As you can see a lipid imaging report of the LipiView, this technology provides the average, maximum, and minimum lipid layer thickness values, and also the tear film dynamics, because this technology detects and can register the blink frequency in order to detect complete and partial blinks, and also to detect delay or incomplete spreading of the tear film. LipiView not, but other interferometers also measure the non-invasive BUT. So the clinical relevance of the interferometry is that it permits to differentiate between evaporative versus aqueous deficient dry eye, guides in the treatment, and also helps monitor treatment outcomes. The advantages is a non-invasive technology, provides objective measurements, is repeatable for follow-up monitoring, and provides real-time dynamics of tear film stability, but is an expensive equipment and requires trained personnel. We have also the non-contact meibomography that is based on the autofluorescence of the healthy meibomian glands when they are illuminated with an infrared light. The healthy glands appear as long, wide, straight structure running vertically inside the lid. In contrast, the diseased glands may look shortened, thin, twist, or even completely absent. With the non-contact mammography, we can obtain a MABO score, that is a grading system that permits to quantify the meibomian gland dysfunction severity. And so currently, some devices, for example, the keratograph or the LipiView 2, are commercially available for this purpose. The advantage of the non-contact mammography is that it's a non-invasive technology, is comfortable for the patient compared with the traditional contact mammography, and provides real-time imaging and allows a longitudinal monitoring of the meibomian gland health. So it can be used for the diagnosis and the severity of the meibomian gland dysfunction, guides in the treatment decisions, and also is helpful for monitoring treatment outcomes. And now we have also some all-in-one devices. For example, the keratograph, in only a few seconds, offers the possibility to measure the non-invasive T-bud, the lipid layer thickness, the tear meniscus height, and the mammography and the bulbar redness. We have also the anterior segment OCT that permits a direct visualization of all the corneal layers and the precorneal tear film. With this technology, we can detect some corneal abrasion without the need of dyes. It's also useful in the follow-up of microbial infection diseases, and it has been listed by the International Dry Eye Workshop as a potential diagnostic tool for dry eye, because we can check the meibomian glands with good agreement with the infrared mammography. We can detect the lid parallel conjunctival folds that are frequently seen in dry eye disease at the slim lab. With OCT, we will have more details of its morphology and area. We can also measure the precorneal tear film thickness, but only with ultralight resolution OCTs. But with technical improvements, maybe in the future, the anterior segment OCT will provide the tear film dynamics or the measurement of the lipid layer. And also, the OCT permits to evaluate the tear meniscus height that we can see at the slim lab. With the OCT, we can measure not only the height, but also the area, the volume, the depth, and the radius of the tear meniscus, helping to differentiate an aqueous deficient versus an evaporative dry eye, with the advantages of good repeatability and avoiding the reflex tearing due to the bright light in the slim lab. And finally, we have the confocal microscopy. That is a high-resolution imaging technique used to visualize all the layers of the cornea in vivo, but in comparison with the OCT, we can analyze a smaller field of view. It's very important in the diagnosis and treatment of the acanthamoeba keratitis, but also with other infections, we have excellent images, and also for the diagnosis of the dry eye. We can measure the epithelial cell density with this technology. Also, as I've said before, we can detect in these cases an increased number of dendritic cells and changes in these cells. Also, in dry eye disease, we can detect a loss and damage of corneal nerves, a reduction of the nerves, and an increase in the tortuosity, and is an interesting surrogate for an objective evaluation of the efficacy of different treatments. As you can see here, this is a patient before and 6 months after with a treatment with cyclosporine, and we can see the improvement in the epithelial cell density and in nerve parameters. We can also measure the global cell density with less times consuming than impression cytology, and also we can obtain images of the meibomian glands. This technology is also useful for peripheral neuropathies in order to evaluate the corneal nerve regeneration after treatments. And also our group has used this technology for evaluating and for a better understanding of the corneal wound healing and the nerve regeneration after corneal refractive surgery. The advantages of the corneal microscopy is that it offers a real-time in vivo histology, provides objective measurements of all the layers of the cornea, is repeatable, and is useful for disease monitoring and treatment response, but it offers a small field of view, is time-consuming, and it has some discomfort for the patient. So, being more cost-effective in the short term, in the long term, the use of ocular imaging in ocular surface disease can lead to more it's possible? Yes, thank you. Can lead to more individualized diagnosis and treatment decision that is beneficial for both patients and healthcare system. Imaging is more objective and provides good documentation, leading to an improvement in patient follow-up and education. So maybe with this technology, in the next years, we will need to redefine the algorithm of ocular surface disease diagnosis and treatment, and we need to work in all-in-one or at least several-in-one devices that offers less time consuming and permits a multimodal diagnosis. Thank you for your attention.